Okay, we can get started. Good afternoon, everyone. This is Nelly Poyak from Dana Farber. Welcome to our DFHCC LLS Society seminar series. And as a reminder, like we posting the slides on the website, the DFHCC website that's shown on this first slide. And as a reminder also, we have a Q&A session at the end. Please enter your questions in a Q&A function in the Zoom. And then the speaker will try to answer as many as we can live and has access to remainder of the questions and can get back to you on those as well. It's my pleasure to introduce today's speaker, Timothy Rebeck, who's a Vincent Gregory Jr. Professor of Cancer Prevention and the director of the Zhu Family Center for Global Cancer Prevention at the Harvard T.H. Chan School of Public Health. And he's in the associate director for cancer equity and engagement at the Dana Farber Harvard Cancer Center and in the division of population sciences at Dana Farber Cancer Institute. And Tim will talk about the cancer prevention and early detection in the precision medicine era. Thank you, Tim.
Thank you, Nelly. Thank you for everyone for inviting me. Can you hear me and see my slides okay?
Yep.
Good. So I'm really glad to be presenting in this seminar series on prevention and early detection and how we can begin to think about the use of molecular and mechanistic knowledge in order to improve our ability to develop and then to implement these kinds of prevention and early detection strategies. So let me start by giving you an overview of how we can think about approaches to cancer prevention and early detection overall. So I think you're all aware of many of the approaches that have been used in the general population. So for example, we know that we have the ability to change laws and norms like cigarette taxes or having smoking bans in public places. HPV vaccination, things like that are approaches that can be done in everyone in the population. And these kinds of approaches have had huge impact on our ability to mitigate cancer risk factors as well as lower cancer risk and mortality in whole populations. So they're incredibly valuable. And I want to make sure that it's clear that everything I'm going to say going forward is not to diminish the importance of population level preventive strategies. But I think that based on our growing knowledge of the biological basis of cancer and carcinogenesis, that we can begin to think about in some subsets of the population how to improve the targeting of these prevention and early detection strategies based around knowledge of of the mechanism. We also have, as you know, plenty of examples of people who are exposed and at risk that are at elevated risk, not general population level people, but people who might be benefiting from certain kinds of exposure avoidance, chemo prevention, early detection strategies. So the example is low dose CT screening for lung cancer, which is clearly has efficacy and is cost effective. But it isn't something that you would do in the entire population. You would do it in people who have been smokers or are increased risk of developing a lung cancer. So that's a sort of a second level. And I think that we can expand that a little bit or refine that a little bit to think about precision prevention and early detection, where we can begin to think about mechanism-based interventions. These can include genetic susceptibility or the existence of preneoplasia and the biology of preneoplasia to help us identify those individuals who are at elevated risk and to discover and implement technologies, methods that will help us to intervene and reduce cancer rates and mortalities, et cetera, in these extremely high-risk people. And this is really a corollary to precision medicine approaches that you're all very well familiar with that are mechanism-based treatments and disease monitoring. So on that background, let me just give you one example to drive home the point that population-based, population-level approaches really have an impact. So I gave you initially the example of smoking, but there's one that's really incredibly compelling, and that's the effect of economic and social change on liver cancer as it's happened in China. So as you can see on this slide, this is a summary of a lot of work over many decades But you can see that that China has made some really interesting inroads into reducing liver cancer risk factors and liver cancer risk and mortality. This started in the 1970s, 1980s, when the Chinese government started allowing people to grow their own crops and sell them. And so a lot of China went from a maize or corn-based economy to a rice-based economy. Maize is a host for aflatoxin. Rice is not. People change their drinking water patterns, and these kinds of exposure changes through economic principles really change the pattern of risk exposures. At the same time, so that as you can see, the aflatoxin albumin addicts in the gray bars have dropped substantially. At the same time, the HBV vaccination was implemented in China. And so you can see that what happened is that the average age of liver cancer went up, and the average incidence of liver cancer really dropped. And that's an incredible population-based success story of how you can address liver cancer through social, economic, and vaccine kinds of approaches. And just as a note, that's changing a little bit now because of the increase in China of obesity, type 2 diabetes, etc. So just suffice to say that we can make a huge amount of impact on cancer through population level changes. But prevention and early detection is tricky. And there are a lot of limitations to current approaches. And obviously, the list that I could give is incredibly long. But I think the problem that we often find with cancer prevention and early detection is that success is invisible. What we may have is the years or decades worth of interventions that may be required, and the end result is that nothing happens. Somebody's not diagnosed with cancer. And that's a problem, because if you have need to have people motivated over a long period of time for nothing to happen. It's almost like COVID-19. If we do all the things that we're supposed to with testing and social isolation and social distancing, nothing happens or less happens. And that's difficult for people to wrap their heads around, as you have all recently seen. Same thing with prevention and early detection strategies. This lack of drama in sort of doing a lot of things with a cost and seeing nothing happen is no cancers being diagnosed is difficult. These statistical lives have little emotional effect. We can say to people, well, we'll reduce your cancer risk by 20%. That's not something that individuals are motivated by. Again, COVID-19, we've all seen that recently. Same thing with cancer prevention. And it's also difficult because this persistent behavior change may be required. We may ask people to change their diet or their lifestyle, or to have take chemopreventive agents or something like that over a long period of time. It's difficult for people to take easily. Also, advice is inconsistent or changes over time. And that's a good thing, in the sense that we're probably learning more and getting a better ability to have better and more effective interventions, but it confuses people because the advice is going to be different tomorrow than it was today, and people don't know what to think or what to believe or what is right. And the other problem with cancer prevention is that commercial interests may conflict with these prevention goals. So, the tobacco companies' interest in selling cigarettes is very conflicting with our interest in preventing smoking-related cancers. So these are things that are limitations of cancer prevention. And again, when I see what's happening with COVID-19 and where we're living right now, you get a real, it hits home the message of why prevention strategies are really difficult for populations to implement. So the reason that this is important, both for COVID-19 as well as for cancer prevention long-term, is that the risks and the costs and the benefits have to align for the individual, and they don't always do that. So one way to help make these things align is to get, for some people who are at extremely high risk, or who have risk factors or have are in a setting in which the benefit can be made clear to them, we should be able to have a stronger motivation, a stronger message, and stronger interventions to be able to align what their interests are in terms of preventing disease risk and how we talk to them about it. So this is where precision prevention can come in, and I'll try to walk you through a little bit of that. So who benefits when we try to prevent cancer? So one of the problems is that equally applied cancer prevention and early detection works best if everybody's the same. So on this cartoon here, you can see we have equality. If we say we're going to just do the same thing in everybody, that's okay as long as everybody will benefit the same and has the same needs. So for HPV vaccination or stopping smoking, an equal population-based approach is appropriate. However, we know that there are many individual differences by race, by genomics, by exposures, by response to interventions. And so we need to come up with a more equitable approach that tailors the intervention, the prevention, the early detection strategy around the individual characteristics of the people who may benefit from it, and minimize toxicities and make it so that individuals can see the motivation for why they're doing these things. So we're talking about moving from a everybody stop smoking to a let's refine interventions based around individual characteristics, in particular biology and mechanism that we can understand. So if we want to think about what the definition of precision prevention and early detection might be, it could be the identification and use of biologically based mechanisms to prevent or intercept cancer development, progression, or recurrence or metastases. So when I think of these concepts, I think of them all the way across the cancer continuum, from normal to precancer to invasive cancer to metastases, and in which we want to think about approaches that will prevent, detect, intercept, and monitor cancer across the continuum. So oftentimes when we think about prevention and early detection, we think about the left-hand side of this, preventing cancers from arising. But I think that we should be thinking about the entire spectrum of the cancer continuum. So we can focus on those at elevated risk, because they've inherited a genetic susceptibility or have a major exposure. We can think about how to intervene at the optimal time point. We can think about how to downshift stage, meaning if people are diagnosed, we want them to be diagnosed as early as possible so that we have a more treatable cancer, and understanding the biology of this carcinogenesis pathway and the underlying risk that is conferred the disease, link those to relevant therapies, because ultimately not all cancers can be prevented. Some will be detected early. Anyone's diagnosed will need to be treated. So it's a continuum, and we need to think about the concepts all the way across. So here's one way to think about how we can achieve equitable outcomes without maximizing toxicities. So here's just a cartoon of this. So on the x-axis is efficacy. How effective is the intervention or the screening tool or the preventive strategy, low to high? And on the y-axis, how many toxicities are there? What is the cost-benefit ratio of applying these kinds of approaches? So we can imagine that there's a line here, an imaginary line, where above the line, toxicities are greater than the efficacy. So in that space, we would say this is not really a good approach. This is something that has more harm than benefit. And below that line, more benefit than harm. And so if we think about what the population might look like, let's say that everybody in the population is represented by this oval. So if you apply an intervention or a preventive strategy or an early detection strategy, it may have some efficacy in detecting cancers early or preventing cancers. It may also have some toxicities associated with it. And those toxicities might be financial toxicities, they might be biological toxicities, they might be medical toxicities, many different kinds that we can think about. But really in the population, what we have are some individuals who will experience much greater toxicity than efficacy. So there is an unacceptable cost-benefit ratio to some people in the population. And so we wouldn't want to be intervening on those people. So again, if we're talking about HPV vaccination or stopping smoking, that's probably a minimal group of people. But if we're talking about applying a chemotherapeutic or chemopreventive agents, or maybe screening tools, there may be people who will not benefit. And we need to understand who those people are. Of course, there may be other people who will benefit a lot, but there may be toxicities associated with that intervention. So that may be okay if the risk is high enough and the efficacy of the intervention is high enough. It may be okay. Some people may accept toxicities, but in general, historically, many preventive strategies have failed or have not been developed because the philosophy among people who develop these strategies is that for prevention of cancer or for early detection, really any toxicity is unacceptable, or very low toxicity levels have to be maintained for people to accept it. But we have to think carefully about that, because there may be some individuals who have very high risk and could accept or could benefit despite the toxicities. And obviously what we're trying to find are those interventions and those subgroups of people in which we have a very high efficacy and very low toxicity. And those are the kinds of approaches that we need to be thinking about, but they may not be optimal approaches for everyone in the population, maybe just for a subset. So let's walk through what that subset of people might be, how we might be able to identify those interventions through understanding biology better. So if we think about the mechanistic foundation of what a precision approach might look like, we can start asking questions across the cancer continuum, like, is there a potentially molecularly or biologically defined window in which carcinogenic events are reversible or modifiable? So what's the sweet spot for thinking about when we should be intervening? Obviously, intervening too early can be a problem. Maybe there are greater toxicities, or maybe the events haven't occurred yet, so we can't really find risk because unless there's, say, germline inherited variation, they're not there yet. If it's gone too late, it may not be that we can really modify them. We're talking about early detection, or we're talking about treatment, but we're not talking about being able to have the maximal impact if it's too early or too late. We can also ask, are there events in this window that identify target agents or interventions? So this is where the biology comes in. If we understand the biology in this window, then we can use that knowledge to develop the interventions that are most effective, et cetera. We can also think about whether there are biomarkers that hallmark these events. Obviously, if we're talking about screening, a biomarker that hallmarks the events in this window would be really useful to have. And they may be biochemical, genomic biomarkers, but they could be imaging biomarkers. There could be a lot of different things that we could think about in this space. And then finally, can we use this knowledge to identify groups in who we should intervene? So again, not all individuals may benefit. The more individuals that can benefit, the better. But it may be that we're talking about a relatively small proportion of the population who have the characteristics and can benefit without toxicities from whatever this prevention early detection strategy may be. So we already have a lot of these interventions. I'm not going to list off all of them, but it's not to say that these interventions that are what we might think of as precision don't already exist. So we already know that in certain high-risk individuals, we recommend exposure avoidance more intensely than for the general population. There might be chemopreventive strategies that will benefit people, but maybe only in responders, maybe people with a particular metabolic genotype that will have a particularly good response, and maybe people without that genotype don't have the right response. So this is a precision approach to thinking about how to chemoprevent. Or there might be individuals who are at extremely high risk. And for example, Lynch syndrome patients in cancer who take aspirin or NSAIDs, that chemoprevention is known and is an intervention specifically valuable to people at extremely high risk. We know that there are preventive surgeries in high-risk individuals. So for example, if you have a BRCA1 or BRCA2 mutation, you might have a risk-reducing salpingo oophorectomy in order to reduce risk of ovarian cancer. If you have an APC mutation, a familial adenomatous polyposis, you may have a colectomy, et cetera. Those are not interventions you would do in the general population, or even very high-risk individuals. You would only do them in the highest risk individuals. So that's a precision intervention. Certainly early detection, we use MRI screening in high-risk women with BRCA1 or 2 mutations. We wouldn't do that in the general population. So it's a precision early detection example. And we can monitor. We monitor tumors in patients who have relevant mutational profiles, and I'll give you some examples of some of these in a minute. We also should be thinking about the concept of reverse migration of chemotherapeutic agents back to chemopreventive agents. So the classic example of this is SERMs like tamoxifen that have been used, are used in treating ER-positive breast cancer, but then have migrated earlier into the carcinogenesis pathway to be as chemopreventive agents. It might be that not everyone benefits equally. And of course, drugs that you're giving may have toxicities. So you might only want to give those drugs to some people who will clearly benefit, that their risk is high enough, that the cost-benefit ratio is favorable, et cetera. But these are all things that we already think about a lot. And so this is not necessarily new space that we're talking about, but we really can do a lot more to think about it more carefully in developing and then implementing these strategies. So let me just walk you through a couple of examples as to illustrate the kind of points that I have been talking about and give you a sense. And I'm going to use prostate cancer as the example, since I do a lot of work in prostate cancer, but I think you could almost do a global search and replace of prostate cancer for breast cancer, myeloma, colorectal cancer, many diseases that have very similar features, although the specific examples I'll talk about are unique to prostate cancer. So let me start with talking about what we can do in the sort of prevention, detection, early detection space first. So one of the things that we know, or we have been thinking about, is in prostate cancer, why do we need to consider precise or precision approaches? Why is this something that would benefit some men who are at risk for or have prostate cancer? So as you know, prostate cancer itself has very few risk factors. Certainly there's elevated risk in Black men, men of African descent compared to non-Black men. Men with family history positive have, compared with family history negative, have an increased risk of prostate cancer. Men with certain mutations, BRCA1 and others, have a vastly increased risk of prostate cancer, particularly aggressive prostate cancer. And there are a few risk factors like height, which is not really mutable, of course, but certainly appears to be associated with prostate cancer risk, and obesity in advanced disease, which in theory is mutable, but not easily. So there are relatively few risk factors that we can modify or use to understand how to precisely intervene to prevent death from prostate cancer. And so I'm going to focus on race and family history, mutation status as approaches we might want to think about when we want to develop a precise strategy for dealing with prostate cancer. And the other piece about this is the toxicity, the harm piece. And so as you're also all aware, screening for prostate cancer is tricky. PSA screening for prostate cancer through many organizations, including the U.S. Preventive Services Task Force, has been fraught with trouble. The most recent recommendation has come from the Preventive Services Task Force for men between 55 and 69 years is a grade C, meaning the decision to be screened for prostate cancer should be an individual one, which is not very helpful. I mean, it's not saying don't screen, which it did for a while. It's not saying do screen. It's really leaving it up to the individual and their caregivers. And that's tricky, and that's tough. And men over the age of 70 should not be screened. But I think we also know that there are men in the population who will benefit from screening. There are certainly men who will be harmed from screening. And so how can we begin to think about using knowledge of risk and biology to target those people who are actually going to have a favorable risk-benefit ratio when they undergo screening? So one group of men certainly are those in which we have genetic information. It's an essential characteristic that we use for prevention, early detection, and monitoring in prostate and other cancers. So the Philadelphia Prostate Cancer Consensus Conference, held a couple times, that's just been held recently and is going to be updated, has identified genes that are, when mutated, seem to have very strong association with risk, and these particularly are BRCA1 and BRCA2, particularly BRCA2. DNA mismatch repair genes in Lynch syndrome, and HOXB13 in hereditary prostate cancer. The others what that have been thought of as testing possibilities are not really evidence-based quite yet. But at minimum, we can say there is a subset of the population, perhaps a small one, that have inherited germline mutations in a gene, let's say BRCA2, for which intervention may be warranted, or different intervention than the general population. So we know that BRCA2 mutations confer unfavorable characteristics for the individual. Time to death, and this one example of that, time to death in BRCA2 carriers versus non-carriers. You can see here that there's a substantially earlier and faster time to death in individuals with, all individuals with the BRCA2 mutation in the red, and those initially diagnosed with metastatic disease. So BRCA2 carriage status is a really strong predictor of unfavorable outcomes, and could be used then to guide people into more aggressive screening and interventional kinds of activities. It's also gotten quite complex. So we have recently published that BRCA2 mutations, the mutation-specific risks exist. That is to say, the type of mutation, the location of your mutation might impact on your risk of prostate cancer, and particularly aggressive prostate cancer. So this slide shows the distribution of pathogenic sequence variant carriers in BRCA2 among different groups, along with the known biological binding domains and functional domains in BRCA2. And what we've identified is that there are prostate cancer cluster regions, 2 of them, whereas all cancers, the risk of aggressive disease, or risk of disease, is about 2-fold. Risk of less aggressive disease is about 1.9, but risk of a very aggressive disease, if you have a mutation that disrupts one of these 2 domains, is about 3.8. So just suffice it to say that we believe that BRCA2 is a strong predictor of risk and aggressive disease, but it also might depend on other factors like what mutation you have and where that mutation is and things like that. So the precision, quote unquote, of how we think about these might be a very fine-grained piece of information about what the mutations are and what they do. It might not just be presence or absence of a mutation. So we can begin to think about some really refined ways of making the risk information that we have very precise around specific individuals and their underlying biological propensity to disease. We know that this information is valuable because it is only valuable when it's actionable. And so in order to have the actionability of BRCA2 mutations impact on risk, we need those data. And so there's a couple of things that we know right now. For example, very recently, it was reported through the IMPACT study, an interim report of BRCA2 mutation carriers undergoing prostate cancer screening, so that over 3 years of screening in just about under 3,000 men, BRCA2 carriers compared to non-carriers had a higher incidence of prostate cancer, younger age of diagnosis, and more clinically significant tumors. So that's in a prospectively screened population. So really this reflects the fact that screening is important, and it is going to be detecting more unfavorable tumors. They also showed that, and this is preliminary, but it's very encouraging, that screening with PSA or the 4-kallikrein marker model, the 4K model, may benefit these men. So the area under the curve for the 4K model was 0.73 versus for PSA alone 0.65. So again, what this initial data tells us is that there might be value in a particular type of screening, in this case the 4K model compared to just PSA, in identifying a risk in a very high-risk individual. So we may be able to tailor the specific strategy around an individual's risk. And that, again, is something that needs more work, but these are tools that already exist. These don't need to be invented. We just need to learn how to apply them effectively in individuals who are at very high risk. And not stated here, but I think is apparent, is that it's not the test and the screening that's the problem and been the controversy around early detection for prostate cancer. It's how you use that information. So getting a high PSA and then being funneled into a model, a pathway of over-diagnosis, over-biopsy, over-treatment is the problem. So while we're learning about high-risk individuals, what kinds of approaches might be appropriate, we really need to think carefully about the use of that information and avoiding over-treatment and thus toxicity. And so that's where the precision kind of approaches can occur. We also know that genetic testing, knowing you have a BRCA2 mutation, can change your clinical management. And this is very clear to everybody that, say, a BRCA2 mutation is strongly associated with risk and aggressive disease, but it also identifies individuals who are have certain kinds of tumor characteristics. For example, those with BRCA2 mutations tend to have more intraductal tumors, and could be treated with targeted therapies like PARP inhibition, for example. But we can see that there are other approaches that will work. So Lynch syndrome with microsatellite instability, high Gleason and ductal tumors with a higher tumor mutational burden might benefit from immune checkpoint blockade, for example. So we have not only targeted screening and targeted early detection tools that may be focused around particular underlying genetic susceptibility, but also treatments that can be used. So what about low risk genetic loci associated with prostate cancer? Well, this is a list on this slide of the 167 or so loci that have been associated with prostate cancer risk. Please digest these. It'll be on the quiz for which ones are and aren't prostate cancer risk loci, so look at it carefully. This is obviously very difficult to digest because there are so many of them. So far, the GWAS loci that have been identified explain about a third of familial relative risk. So a substantial amount of familial relative risk. So family history being an important risk factor for prostate cancer. We're beginning to explain that, but out of the 167, or really, I think 313, or however many loci you now think are involved with prostate cancer susceptibility, we're really only explaining a third or so of that, relative risk due to family history. Most of these appear to be what we used to think of as polygenes, an infinite number of genetic loci, each of which conferring a very small impact on risk. So each of these loci has, you know, a relative risk of 1.1, 1.2, very small incremental added risk for each of these. And so any one of these is not going to be useful in understanding an individual's cancer risk. And there's also no evidence for interaction between these genes or exposures. So it's really just the summation of a lot of small bits of information. And we've been able to do that in many settings through polygenic risk scores. So this is an example of a polygenic risk score using 133 of these prostate cancer GWAS hits. And as you can see, you know, you get about an area under the curve of 0.67, 0.68. So you can explain a reasonable amount of the variation in prostate cancer risk. But adding a lot more SNPs is not really helping that much. But you can see, as shown on this slide, there are some individuals, if the percentile of the polygenic risk score is on the x-axis and the relative risk on the y-axis, there are some individuals in the population that are significantly lower than average risk and some that are significantly higher average risk based on these 133 genomic SNPs that have been identified. So you can imagine, again, in a precision setting, if we're able to use this information, this polygene information, we can find some people that are at low risk and thus need less intervention, less screening, and some that may be at very high risk and might need higher amounts of screening. One of the problems is that there really haven't been associations of SNPs. There have been some, but it's been inconsistent with prostate cancer-specific aggressiveness or survival, which is really what we care about. We really need to have more information about and more robust data on aggressive prostate cancer. And again, there is plenty of data out there suggesting that those exist, but that's really the domain in which we're most interested. However, when we think about the value of these SNPs, we also need to think about them in the context of other variables. So if we look at the Stockholm model, which has been published out of Sweden, the multivariate prediction of Gleason 7+ prostate cancers, or some more aggressive prostate cancers, the predictors include PSA, risk factors like age, family history, a series of biomarkers, a genetic score, a polygenic risk score, and other clinical data like prostate volume and DRE. And the reason I show this is because you can get up to a very good area under the curve, a very good prediction, 0.74, if you add all of these things in. Certainly, it's not easy to add all of these things in because it requires a lot of testing, a lot of different markers and different data to put into a model. But assuming that the model looks like it's really good, so if you want to do all of this in a clinical setting, you can get a pretty good prediction. But the thing I want to point out is over here where if you've looked at PSA, risk factors, and biomarkers, you get to a cumulative AUC of 0.68. And if you add 232 SNPs in this case, you get to an AUC of 0.7. And that's been the limitation so far, is that you're really not explaining through these SNPs a lot more variation in risk by adding these SNPs. It's not to say that there aren't some individuals in the population who will benefit, but overall, you're not adding a lot of information. So the question becomes, is it valuable to add these polygenic risk scores or these low penetrance genes into the setting that we're talking about? Some will argue yes, some will argue no, but the full implementation of this information in a prevention setting and a risk stratification setting is really yet to be seen. So let me give you a second example briefly about prostate cancer again, but really thinking a little bit more about the interception and monitoring piece. So we talked a little bit about the left-hand side of this flow. Let's talk a little bit about the right-hand side of this flow. And again, this is where there's a gray or blurry line between prevention, early detection, and treatment. But in my mind, they're a continuum. And we should be able to think about how to use, intercept and monitor and make decisions about cancer management using this precision approach that many of you are familiar with through precision medicine kinds of approaches. So you'll see why, I hope you'll see why I think this is all part of the continuum of prevention, early detection, and decision making, but it definitely intercepts the treatment algorithm as well. And again, in prostate cancer. So let's just take the example of Gleason 6 disease. So Gleason 6 disease is generally thought of as indolent prostate cancer. In fact, there are some groups that have recommended that men diagnosed with Gleason 6 prostate cancer shouldn't even be called cancer. It shouldn't be labeled as such because it's so indolent, it's not really clinically relevant. And we know that's not entirely true, of course, but Gleason 6 disease is generally thought of as something that's low risk. And so let me just talk a little bit about, if we're thinking about a precision setting, I talked a little bit about genetics, and I'm going to talk a little bit more about race, or the characteristics of the individual as a marker, if you will, of precision interventions, not necessarily genomic, but also genomically driven. So the question is, should all men with low risk prostate cancers avoid active treatment? Oftentimes, men who are diagnosed with Gleason 6 disease are recommended to undergo active surveillance or watchful waiting. But we know that there's a higher risk of prostate cancer mortality in Black men with Gleason 6 disease. So you can see over on the left, Gleason 6 disease, Black men in the upper line, prostate cancer specific mortality over time is higher than that in non-Black men. But for Gleason 7 to 10 disease, they're virtually identical. This is work from Brandon Mahal and his group published a couple years ago now in JAMA. And it tells us that there really is, there are men with Gleason 6 disease, particularly Black men, who might need active treatment or might need some kind of additional precision, if you will, approach to how they manage their disease. Brandon and his group also reported that Gleason 6 disease is associated with higher genomic risk scores for Black versus white men. So again, very analogous to what I just showed you. These are Decipher test scores, a genomic test in prostate cancer, for which there's generated a genomic risk score. And as you can see, in Gleason 6 disease, Black men have a much higher genomic risk score than white men, whereas white and Black men have a very similar, non-statistically significant difference in their genomic scores with Gleason 7 through 10 disease. So again, another piece of data suggesting that Black men have increased mortality and may have underlying genomically higher risk. So we can begin to think about an approach where when we're talking about monitoring, not yet treatment, but monitoring for disease, understanding what the pathway is forward for certain men who've been diagnosed with what we can think of as low-risk disease, understanding their race, understanding the underlying genomic profiles of their disease could help in that management. We've got other data presented by Dan Spratt and his colleagues at Astro this past year that Black men have very distinct tumor gene expression versus white men. In particular, DNA repair is very different, depressed in Black men, but also cell cycle pathways and metabolism pathways compared to some of the immune regulatory pathways in Black men that are increased. Interferon gamma, interferon alpha, TNF alpha signaling, et cetera. These appear to be more active in African American men. So again, I think we've begun to learn that not only is race a risk factor for prostate cancer, but the appearance of disease, the nature of the disease in Black men is very different than in white men molecularly and genomically. So we can think about this in terms of implications for screening, monitoring, and treatment. If we understand better what the tumors of Black men are going to look like as we screen them, as we look for certain things that might be identified biomarkers for screening, but also in treatment or monitoring. So imagine that there's men who, Black men have a decreased DNA repair. Does that have implications for their undergoing radiation therapy or chemotherapy or something like that? Does that help us to make the decision as we get a man who's diagnosed with very early disease? How do we make those decisions? Do we use that information, and how to guide monitoring or active surveillance and screening of disease before active treatment? So let me just give on that background of prostate cancer, where we have some sense that there are underlying biological features of prostate cancer that are different in African American versus non-African American men. There are molecular signatures and germline genomic profiles that might guide us to treating the disease differently in different groups of the population. What might this look like in a population? What might precision prevention and early detection look like if we were able to implement it? And to do this, I'd like to introduce the concept that Bill Kissick defined many years ago, called the iron triangle of healthcare. And so this iron triangle considers three elements: cost, access, and quality. So anytime we talk about healthcare, and particularly in the context of screening and early detection, these three elements are what we need to think about. So the relationship between cost and quality tells us about the value that these interventions will have. Cost and access define equity. So again, as I said before, we need to ensure that we have equitable interventions, but also equitable application of these interventions. So in a precision way, we need to do it have cost and access aligned so that the people that need these interventions and will benefit from them can get them. And then the axis of access and quality determines how these things, these elements will act in terms of defining population health. So what happens is that if cost goes up, something else has to go down. If access goes up, something else has to go down. The iron triangle is that these are all bound to one another. So if we think about the distinction between population prevention and precision prevention, this might help guide us about how these elements may be implemented and devised in the future. So, for example, we have Population prevention and early detection, like application of HPV vaccinations, cigarette taxes, colonoscopy, things that everybody should be doing or can do. What you can imagine is that the cost is somewhat lower, not zero, but the cost is relatively low and access can be relatively high in the population. That is to say, we should be able to provide relatively inexpensive, accessible colonoscopies for all individuals over the age of 50. But the quality may drop. And I don't mean quality in terms of how good it is, but the nature of that intervention is blunt. That colonoscopy is a blunt instrument that everybody can use. It's not tailored very much to the individual. It's not tailored to specific risk. It's a blunt instrument, but it allows us to have favorable cost and access. So population prevention and early detection might look something like this. In contrast, precision prevention and early detection, when it goes into into implementation, the cost may be higher because we're talking about implementing molecular tools or molecular testing, and maybe that cost won't be hugely high because those tools and tests can be made cheaper. Access may be lower because, again, you may not want to do all of these things in all the population. And in fact, you want to decrease access. You want to only have access for those people that are really going to benefit from it. So access by definition needs to be limited. But the quality of the intervention, a precision instrument, again, not the actual quality of the specificity and sensitivity per se, but just the fact that it is tailored to the risk of the individual is increased. So for precision prevention and early detection, like using ultra low pass whole genome sequencing in monoclonal gammopathy patients to detect changes in a molecular signature in as they develop myeloma, that's not something you're going to do in everybody in the population. The cost will be higher, the access will be decreased appropriately, and the quality or the precision of the instrument will increase. So we can imagine that in order to achieve both precision prevention and early detection as well as population, we need to have both of these in order to optimize how we get these tools and what tools we get to the people who will need them and benefit from them. So let me just summarize by talking about where I think we are. So precision prevention and early detection, again, we need to focus on genetic susceptibility and individuals with pre-neoplasia. These are biologically driven events that we can use to understand who's at risk and who's on a pathway toward developing disease that can be screened early, intervened in more effectively, et cetera. So those are the two areas that I think we have the opportunity to develop precision prevention and early detection tools now, built around biology. We also need to define and can define a window of opportunity, the sweet spot around which we want to intervene. Where is the optimal time point? What are the optimal biological events? And what are the optimal biomarkers that we need to define in certain groups of individuals in order to figure out the appropriate, optimal, cost-beneficial intervention. We also want to stage shift. We want to think about detecting cancers earlier and earlier so that they are more treatable. And as I mentioned, we need to link all of this to appropriate therapeutics because some cancers will be detected, and there needs to be a thick line drawn between the strategies to detect cancers early around specific biological events and the ultimate treatment of those cancers when they are diagnosed, if we can't prevent them completely. So this is a continuum that I think is how we need to think about the entirety of prevention and early detection using biological and other mechanistic information that is not siloed around specific disciplines of molecular biology versus epidemiology versus behavioral science, but all together because these things are multifactorial, multidisciplinary endeavors if they are all to link together. So let me just say that the precision piece that I've tried to introduce today is not to replace population level efforts. Both have to happen. They have to happen in the right context with the right people at the right time. So they are both valuable and complementary. We need to focus on approaches that foster optimal outcomes and limit toxicities. So we need to focus on at-risk populations, as I mentioned. We need to optimize the timing, we need to stage shift, and we need to do the therapies. So just what I said above. And finally, I think it's really critical, and I would give a whole talk on this, we require diversity in research participants and settings to ensure that all persons will benefit. So as I mentioned in prostate cancer, being African American is one of the largest risk factors for prostate cancer and for unfavorable outcomes for prostate cancer. We can't understand those issues unless we have studies done in African Americans and in populations in which are clinical settings where African Americans are seen and screened and treated. And right now, that's a major limitation for us to be able to have adequate participation and adequate settings to do this work that will benefit all. But this is clearly a key element of our ability to do this precision approach properly, particularly when it involves a race-specific disparity or any other kind of disparity. So on that note, let me end and thank quite a few people who are involved in this work and some of the funding that we've received, mostly from the NIH, but others as well. So I'll stop there and take any questions you may have.
Okay, thanks, Tim, for a great overview of all these challenging topics. And we have a number of questions that each one could be actually a full lecture itself. So one of the questions is about what is the big difference between African-American and non-African-American? And since African-American in the US is still kind of a mixed population, hasn't been this risk difference been demonstrated in African men in Africa?
Yep. So as you can see on the slide that's up now, the work that we are doing, and I didn't present today just because of time, we have a network called the Men of African Descent and Carcinoma of the Prostate, or MADCAP network, that's studying prostate cancer in African American men in North America and African men around Africa to address exactly this question. So there's a few things that we've learned, and many others are doing this too, but that others have learned. And the first one is that the underlying genomic susceptibility patterns for prostate cancer, which is one of the driving things in prostate cancer risk, is genetics, and those genetics appear to differ between African American, African, and other races. It's not to say that the underlying biology is fundamentally different, but that the distribution of susceptibility genes that are driving the risk is different. The genes themselves, but also the alleles and the contribution of those alleles to risk. So there's a lot of evidence suggesting that there are underlying fundamental differences. There is certainly, but that's only one piece of it. And obviously in a place like Africa, most of the prostate cancers are diagnosed at a very late stage and usually untreatable because there is no screening. So, and in the United States, as we're all very well aware, access to care, behavior, things like that, treatment delays, things like that, have a profound impact on mortality. So we don't have a good sense of the relative contribution of genomics and biology versus social determinants, but the social determinants are profound and large, and those definitely impact on the mortality and the aggressiveness of disease and ability to treat it. So it's multifactorial and it's complicated, but we are starting to get a handle on what it looks like in different populations across the African diaspora.
Yes, so one of the questions was related, which you already answered, about the social inequality and the treatment inequality or diagnosis that could influence outcome.
Yeah,
and then
very important. Yeah.
Two other questions still kind of follow up on this. One is, how about the other populations like Hispanic and Native Americans and so on? Mm-hmm. And also in Africa, did you look at more the northern part of Africa? Because based on what you presented, it looks like more like sub-Saharan African countries. So,
yeah, I mean, there is the same principles that I described, mostly focused around Black men, meaning of African descent in the United States. The same kinds of principles apply. The specific situations are different. I think that we can probably predict that underlying genomic factors contribute to risk. and social determinants, healthcare access will be really important in determining outcomes and mortality. But I think that it's important to, and so I don't want to downplay the social determinants and access to care and things like that. I didn't focus on those here, different talk, but I think it's really important to realize that even if we could equalize treatment for all men, if we could put them in a setting where everybody got equal screening, equal access, same time from diagnosis to treatment, they all got the appropriate treatment, we would still have disparities because the underlying risk profiles are so different. So just fixing the treatment inequities or the access inequities, which we have to do, is critical. That won't alone make the disparity go away. Because the risks are so different in these different populations, where Asian men have much lower risk, Hispanic men and white non-Hispanic men have very similar kinds of risks, and African American men have much higher risks. It's a multifactorial problem.
Yeah, so another question is related to early detection in terms of particular the ctDNA progress to use that for early detection, and that could be it's a big topic by itself again. Yep. If you could just summarize recent advances and which diseases maybe it's more promising than others.
Yeah, so you know, there's a lot of great work going on this topic that is very promising. ctDNA and some of the other liquid biopsy methods seem to be most effective or most useful at this time in detecting active existing disease, so minimal residual disease monitoring. Seems to be the place where most people are thinking more about the development and the implementation of these liquid biopsy methods, because there's enough DNA, there's a tumor there, they can for study, and it's much more difficult. It has been much more difficult to translate these same tools into an early detection setting, and probably a lot of that is a limit of detection. So if you're talking, and you can walk through the math, but if you imagine how many molecules in per volume of blood exist in an individual with a very early lesion, perhaps one that has not, is tiny, you can imagine how little of these molecules, DNA or other circulating cell material, that would need to be present and detectable for this to be useful as a screening tool. So right now, that limit of detection is really a problem. And there are some very clever people working on this, of course. There are people looking at this from a protein standpoint, who are looking at proteins which have different properties, but maybe allow us to have very, very low limits of detection. There are people that are thinking about methods to enhance the quantity of these molecules through, clever techniques, to increase them so that the assay can pick up a very small amount, almost like a PCR to amplify the signal. And this is plenty of these different kinds of technologies working right now, but I would say that in terms of early detection, it's very, very early technology-wise for us to be able to think about them being useful in any kind of a setting, like, well, any cancer setting, really.
Mm-hmm. Okay. I mean, in discussing in terms of early detection in breast cancer, and I guess in prostate also, there has been this debate that we actually detecting too many cancers that would never be like clinically relevant. The DCIS
Yep.
just in the US, it's like over 40,000 women a year. Right. And it's, not gonna kill you. But so how could we detect and prevent cancers that actually gonna be, contributing to mortality? How can we differentiate that?
Yeah, I think that was really is one of the major points of a precision approach. And in the prostate cancer setting, thinking about this Gleason 6 disease, thinking about disease that is indolent, or we think of as indolent, is true overall, but it's not true for everybody. Mm-hmm. And by the same token, DCIS in some women, in most women, is probably an indolent event that may not need treatment, but for some women it will. And so the question is, when you have these intermediate, early, either pre-neoplastic lesions or early cancers with favorable histopathological characteristics, what do you do with them? and when you detect them? How do you monitor them? So I think that's where this precision approach really comes in, is by using knowledge of an individual's genetic susceptibility. If they have an early lesion, but their genotype, their underlying genome suggests that they are very likely to develop an aggressive disease, they might be it might be necessary for them to undergo more intensive interventions of whatever kind. If their tumor profile looks like it's can be monitored over time and look for changes to the tumor profile, that can be a monitoring tool that will trigger a treatment intervention, and that most people who have these indolent or preneoplastic diseases don't have to undergo treatment until their molecular profile changes to the point that we feel like it's headed toward a bad outcome. So there's a lot of opportunity there, and I think that, again, our goal is to minimize treatment to those people that are most likely to die, and avoid over-treatment in people who will not suffer from the disease long-term. So that's the precision concept. Yep.
Just one last question, because it's just, I'm sure it's coming up. So there's more and more data suggesting that cancer risk and also the risk of progression is influenced by immune status of the host. So how can we incorporate that into, determining your risk?
Yeah, so I mean, there's a lot of different ways that can be thought about. So certainly in terms of risk, if we can identify, as I was saying, a window that contains in which biological events are occurring with biomarkers, that we should be able to say, what is the immune profile of an individual? Let's say they have an early lesion. This is a little more difficult in prostate cancer than some others, but they have an early lesion, or they have a preneoplastic lesion. What is the immune milieu of that lesion? You could talk about microenvironment. You can talk about a lot of other similar kinds of patterns, and think about how to use those to monitor screen as that, first of all, in terms of risk stratification, but second of all, in terms of progression. Is the immune milieu changing over time? So again, I don't have good examples in the prostate world, because prostate is trickier. Inflammation might be a better example in prostate cancer, although immune surveillance is certainly very interesting. But I think that these biomarkers and these biological events over time can certainly lead to stratification of risk, stratification of the likelihood of progression, as well as monitoring. So again, that's a very generic answer, but it seems like it has a lot of promise.
Okay, thank you very much, Tim. Great talk. Thank you, everybody, for attending. And again, a reminder that the slides will be posted on the website later today. Thank you.